Hi, welcome to the Doctor Who Show. I'm your host, Nick Cicero. Our guest today is Dr. Alyssa Brotman O'Neill, a board-certified vascular surgeon. Dr. Brotman O'Neill is recognized as a leader in the field of venous disease, including varicose veins and the disorder of the deep venous system. She was present for the first venous Claire-vein procedure on humans in the United States and was the first to perform this technique in Mercer County, New Jersey. She currently practices at Princeton Vascular Center in Princeton, New Jersey. Please welcome Dr. Alyssa Brotman O'Neill. All right, thank you for joining us today.
Thank you.
So where did you grow up?
I grew up in Hamilton, New Jersey, which is by Trenton, and I went to Steinert High School, and I grew up pretty much my whole life there.
Yeah, are you only child, or you have any siblings?
I have an older sister and two younger brothers.
Okay, so growing up, was there a lot of competition in the family?
I don't know that there was competition, but we all pretty much got along, and we were always into education, as were my parents. They really stressed that as an important part of our upbringing.
Yeah, did they want to be doctors as well?
My siblings?
Yeah.
My sister is an ophthalmologist.
Oh, okay.
Yeah, my two younger brothers are attorneys.
Oh, that's great. That's what I want. I have a son and a daughter. I want my daughter to be a neurologist or a neurosurgeon, and I want my son to be a lawyer. So
there you go.
I want both in the family. You know, it's a good way to do it that way. So you said your parents were really pressing on education.
They believed in education, that was pretty much fundamental in growing up.
Yeah, and when you were in high school, did you have an inkling that you wanted to be a doctor?
I always was the science geek almost,
okay.
Although I hid it behind my running. And yes, I mean, I did science experiments in my basement with Drosophila.
Oh wait, I want to hear more about this.
And yeah, I think that I really not only wanted to be a doctor, but very early on wanted to be a surgeon.
All right, what was your first science experiment in the basement?
Well, in high school, I wanted to see grow Drosophila. I had this idea that the electromagnetic waves were bad, so I bred them and exposed them to electromagnetic waves and looked at their generations and the rate of death. And it turns out, if I can remember correctly, that they did have an effect on the rate of breeding on Drosophila.
So you were correct.
Nice. Yeah, and it took me to Nashville, which was nice, for the International Science Fair. So
oh, really?
Great.
So
yeah.
So first you had a theory, then you had to prove the theory, and then you used it for high school, and then they submitted it to like a state competition or a national competition?
The county fair to the International Science Fair. It was nice.
That's cool.
Yeah.
Did you win?
I came in third.
Hey, out of everybody, that's really good.
So.
I had not nearly the same story, but I had a knack for metal shop. So I could weld when I was a freshman in high school, and I would make these art sculptures. And my teacher was like, "Hey, do you mind if I submit 2 of your sculptures to the state fair?" And I'm like, "Sure." You know, what do I know? I'm a freshman in high school, and they won.
That's amazing.
Yeah, it was
great.
pretty cool.
Yeah.
I was excited. So I get that
that
feeling you
really
must have
cool.
had, just being there and doing that. So you're like a Sheldon Cooper then.
I don't know about that. But
Oh man. So what college did you end up going to for your undergrad after high school?
I did. I went to Harvard University for my undergraduate.
Wow.
So.
Was that your first choice?
It was one of my first choices. I had gotten into an 8-year or 7-year medical program, and I was deciding between that and Harvard, and ultimately chose Harvard. I really liked the running coach at Harvard, and I ran at Harvard.
Oh, so you ran at Harvard?
Mm-hmm. And,
that's D1?
It is.
Wow, good.
Yep.
Wow, D1 runner. Now, were you long distance?
I was, I don't have fast twitch muscle fibers in my body, so
for sprinting?
I'm a long distance runner, and so I ran in college, and stayed on the path of pre-med. It was also another reason to choose it, because I thought that would test me. Do I really want to become a doctor and not choose the medical program right from high school? But it turns out that is really where my passion lied.
Yeah. How did you manage the stress level for being a Division I runner and getting your studies done in Harvard? Like, was the first a year of that very tough, or did you adapt to it very, very quickly?
I mean, honestly, I think that running has really helped me in focusing, and it's my meditation. So I really thought about running first, even almost sometimes before academics. It was a primary focus of me growing up, and sometimes if I had a thought or I couldn't figure something out, I just go for a run and figure it out on the run. It's really a calming, soothing, and it also teaches you time management. I think all sports are really important for physical and mental well-being. And as a physician and a vascular surgeon, I see that as well. It's important to maintain your health and your mental health by being physically active.
So one helped the other.
Yeah, pretty much. But I think that, Harvard was difficult in that there are rigorous courses with obviously pretty academically rigorous types of people. So, but yeah, I really enjoyed my time there. I made great friends, and I really enjoyed the sciences.
Well, that's great. Did the running take you places all around the country?
I think
How did that work?
Well, we practiced at a certain time of the day, and then we had our competition.
So the meets would take you places.
Yeah.
Well, that was fun. So that's kind of gives you a little break from all the all the academic parts of it. You get to run, you get to relax, and then you came back and you're good to work on all your stuff. So when did you really hunker down on becoming a doctor? Was it your second year, your third year at Harvard?
I think it was well before that. I mean, it was really as a little kid. It was something that I always knew I wanted to do. And
you had the doctor set as a kid?
I did, and well, I don't know if I had the doctor set, but I really thought about it, and I thought about the fact that I wanted to be on my feet and be physically active too, and figure out problems. And so I liked running, I liked something physical, and being a surgeon, it sort of went hand in hand. So I think that it was just something that was part of the course.
That's awesome. So by your senior year, did you start to look for medical schools and see which way you wanted to go and where?
Yeah, I always thought part of my work in college was looking at the mind-body connection and all of that, and so I had really thought about where I wanted to go to school and med school and how to incorporate that into being a surgeon, and so I did, yeah.
So you knew you wanted to be a surgeon early on?
I did.
But did you know what surgery you wanted to practice, whether it was ortho or neuro or lower body?
No, I really didn't know what type, and I knew that I wanted to incorporate the whole human being in terms of surgery, so I thought that it was important to, study all different types of medicine, including internal medicine, and also what effect we have on ourselves in terms of disease.
Sure. And then what brought you to vascular surgery?
Well, I think that vascular surgery, especially at the time that I was training, was sort of like the internet boom. It had a lot of intricate surgeries in terms of doing anastomoses, which is, really tiny suturing that's tedious work, which I liked, but it also was a boom in technology. It was a time where everyone was being treated with a minimally invasive approach, and these limits have been pushed from the time that I was in med school to now and are continuing to be pushed so that we can enter an artery or a vein with a very small puncture wound and treat the vessel from within the artery itself and not make huge open incisions. And all of that came down to wires, catheters, computers, and really looking at imaging and figuring these things out with new technology. So it was really the old and the new, and it's really exciting.
Yeah, it sounds like you were in the sweet spot of where that industry, the tech part and the surgery part, was growing together at a very high rate.
Correct.
So by the time you got out of medical school, I bet you the tech already passed what you were using and kept going.
It continues to exponentially expand, and it's just really, I think, an exciting time in medicine in general with what we have technologically.
So just to bring back to that one part about those small sutures, so you do have the ability, like a plastic surgeon, to do that small work that they train for, correct?
Yeah, there are definitely certain areas of surgery where you need to use very fine suture. And in fact, in vascular, we use what we call loops so that you can magnify the suture. For example, if you operate on a blockage within an artery, you have to make an incision, clean out the blockage, and then use either vein or some type of material to to anastomose it back or resuture it back. And so that is done really under a microscope, and it is very fine, tedious work.
Oh, so while you're doing the surgery, your eyes are up against a microscope?
Not a microscope, but they're called loupes, so they're special glasses
Yeah,
that you wear.
I wouldn't know. Yeah.
So, but it magnifies the operating area.
So why do you like treating venous disease?
I think that venous disease is an art as well as a surgery. When someone comes in to see me, they oftentimes have pain, but they also have ugly varicose veins that they consider ugly. And while it's most important to be functional and be active and walking, this we can correct, but it's also something that you have to look at as almost like a chess game. It's a bunch of tubes, and if you have to correct one thing first to get to the next step in order to have a perfect result. So I think that it's really almost all exciting in that you can look at a patient and come up with a plan and then follow through on it, and by the end of the time you really have a really nice leg, and the patient feels like they're lighter and they can go work out and they can do everything that they used to do before they develop varicose veins.
Well, I always say pain always brings people into the doctor, right?
True.
They won't go for anything else, but if they're at that point where it's like, oh, can't walk, can't do this, the pain will bring them in.
Right.
And then if you tell them on top of that, hey, I'll be able to take those varicose veins and get rid of them for you and clean that part up for you, I think that's an added bonus and just keeps people moving in the right directions of getting those things done instead of sitting on them. I mean, I remember my grandparents, my grandmother, she had a bunch of sisters, and they all had them. All of them, every one of them. And they just, they didn't care. They hurt them a little bit, they did this, but there really wasn't anything in the 70s that was going to do what they're doing now, correct?
No, correct. In the 70s, they used what we called stripping. It was, you had to go to the hospital and go under anesthesia and make an incision, and you used a tool to really, pull out the big vein. Whereas today, again, we use a laser catheter inside the vein and are able to close it and then remove the varicose veins through really tiny incisions.
So you're talking in the 70s, the recovery time was huge, probably.
I think that they had pain post-operatively, whereas now people walk and go home and they're fine.
So now you can do them in the same day, and
we do them in our office. Yes.
Oh wow!
And it's done in an office setting, and yes, people come in, they have their procedure, and they can leave.
You were the witness to the first Claire vein procedure in the United States, and then the first to perform it on a patient in Mercer County. Talk about that experience for me.
I think it was exciting where I trained. I did a vascular surgery fellowship at Englewood, and I was able to be part of the first Claire vein procedure on humans in the United States. And it was really exciting because a lot of times we use what we call heat to heat the vein shut. There are different ways we can heat a vein shut, all through catheters within the vein, but this was the first time we didn't have to heat a vein shut. And the problem with heat is it does put you at risk for nerve damage. So this is the first time where we're not using heat and injecting medicine and using a catheter to shut the vein, and so that there was no risk of nerve damage. And it allowed us to treat veins well below the knee and also treat ulcers that form or wounds that form because of bad veins. And it allowed us to treat those in a very distal or lower portion of the leg closer to the foot.
When you talk about ulcers, would that include people with diabetes that get ulcers in those areas, or is that something totally different?
There's a lot of different reasons why people get wounds on the feet, and I think this brings up a pretty important point that people who treat vein disease should know about wounds in general from a vascular standpoint. There's many different reasons why people get wounds. They can have bad arterial supply, meaning the arteries aren't working appropriately. They can also have bad venous supply, meaning the veins aren't working appropriately. And there are also diabetic ulcers, which can have a combination of the two. And of course, there's many other different pathologies, such as skin cancer and things like that. But I think it's important to be able to know the differential diagnosis or why this patient has these wounds.
So it seems like it's a vast array of symptoms that you treat. It's not just the varicose veins and worrying about the nerves. There's a lot that you can go in when you first see somebody. You have a lot to look at, almost like detective trying to figure it out.
True. I mean, I think that I love the specialty of venous work because
Yeah.
it is such an art. But I think it's important to point out that there's a lot of different vein centers just popping up, and I think the real difference, and the patient really has to know that if you're treated by a board-certified vascular surgeon, you've not only gone through 5 years of general surgery residency after medical school, you've also gone to 2 years of vascular surgery training in addition to that, which deals in depth with the surgery of arteries and veins. And so there is in detail and in-depth training from a board-certified vascular surgeon when treating this.
Well, that's good for all the people out there watching this right now. You should definitely make sure you have a board-certified, fellowship-trained in that particular, the medical part of what you want to do. So if it's shoulder orthopedic and they have a fellowship in shoulder, that's where you should go.
Correct.
And if they have vein issues, they need someone like you.
Correct.
Yeah, that makes a big difference.
Mm-hmm.
So when you go to residency, do you, is that when you go to, you're focusing on what you're going to be doing your entire life, or you do a little bit of everything? You do a little bit of ortho, you do a little bit of disease, you do a little bit of, is that residency?
So residency for me was general surgery, and I
Okay.
knew that I wanted to go beyond general surgery to vascular, but
Okay.
it's sometimes the start and sometimes the end. Some people end up as general surgeons, and you don't have to go on, obviously.
Sure.
The first year is internship, and you have a lot of medical background then, treating, in the ICU and heart failure and reading EKGs and in the ER. But after that, it's primarily focused
You're
on
focused
surgery.
on where you want to be. And you have kids?
I have 2 kids, 7 and 9.
Boys, girls?
2 girls.
2
Yeah.
girls, 7 and 9. My kids are 2 and 4, so I'm still running after
You are.
everybody
Right.
and changing diapers. You're kind of on cruise control. With all
7
that.
and 9, no, 7 and 9 is still, it gets busy.
Oh, tell me, because I need
need
the
to know.
future. I need to know the future.
My 9-year-old really likes music. She loves to sing and play violin and drums.
Okay.
And my younger one likes to dance and run. They both like to run with me, which is great. It's a good bonding
That's in the
time.
blood.
Yeah.
Wow.
So, and I like to stress education as well. So.
At that age, can they run like a couple of miles?
Oh, they run 5Ks with me.
Get out of here.
Mhm. Yeah, we got them going running.
Oh, wow. So what time, because I run too, but I don't run like you. I just do a 3-mile run once a week, and maybe, and I do some 1.5-mile runs under 12 minutes. Like that's my 2 runs that I do. I don't do anything more than that. But when should I start getting them into that?
I think kids run all the time. They run in soccer, they run
Yeah.
in softball. So it's not a matter, kids like to run. I think it's important not to overdo it and keep it fun, because they are still, little and they have to have fun.
Yeah.
So,
How old were they when you first took them on a run? How did you get them to do it?
well, I took them on a run in their strollers, so they've
Oh,
been,
okay.
yeah. And then they gradually wanted to get out of the stroller.
Were
'cause
those
it got
easy to
boring.
use?
They're heavy.
They
but
are
Yeah,
heavy.
they are heavy, yeah.
Because I lived in the city for a while, and I would always see moms with them
Jogging.
with the big wheel in the front. I'm wondering, is it easy to keep it going straight, or or you start leaning on one side and start moving
You
it?
just have to be careful.
But it's
yeah,
pretty good.
Yeah.
How much do you run now a week? Do you get a good couple of runs in?
I run like 5 times a week.
Oh, okay.
so.
Did you ever do any marathons?
I've not yet done a marathon.
Is that
Half
something on your
marathon,
bucket
but
list?
not it could be. Yeah, maybe.
Yeah. So you did the half marathon. Was that 13?
13.
Was that?
That's fine.
Breezed it?
Oh, well, I don't know if it's a breeze. It depends how fast you run. I was running conversational pace.
Yeah, my brother-in-law, he's training. He's a fireman in Brooklyn right now, and he's training for his first New York City marathon. And he dropped a ton of weight. Like he's a big guy too, like 6'1", like 225, and now he's like almost under 200 already. And he's running like 13 miles, and he's like, I don't know how I'm gonna run the 26. Like, because my program doesn't take me past like 13 or 14. Maybe you can do 16 or 17. He goes, but I guess after that I'll find out.
Right.
Yeah, I'll hit that mark. I'm like, am I going to make it now? You never know. How's being a mom changed you regarding being a doctor?
I think being a mom and a surgeon is actually really complicated. I think that my kids have learned that sometimes I need to take care of other people instead of them, that at that time they take precedence over my children, and they feel that, but at the same time they realize that you can be a mom and a surgeon, and they realize the dedication it takes to be a surgeon. So I think that overall they're proud, but it raises complex issues. But overall, I think it's great.
When you were applying for those fellowships in vascular surgery, was there a lot of women that were applying for those?
I think the great thing about vascular surgery is that there are more and more women entering. When I graduated across the country, there were 6% females. And within the last 5 to 10 years, it's grown again exponentially. So we're going to, I think, over the next few years, reach 50%.
Yeah. Tell me about your current practice.
So it's really exciting. We opened Princeton Vascular Center in April, and we're right in Princeton, and we have
Perfect name.
Outpatient center where we treat all veins on an outpatient basis.
Right.
We also can do arterial work, minimally invasive endovascular, all breadths of arterial work, PAD, aortic aneurysms. And also I do spinal exposure for the spine surgeons. And we're starting also wellness and hair restoration as well.
So what you're saying is patients can come see you for initial consult. You can diagnose what's going on with them, and you can do most of the procedures right there at that address.
We can do all the venous aspects.
Oh, okay.
And hair restoration right at our office.
Is there any time that you would need to do it at a hospital for a patient?
Certainly, you know, the exposures for the spine are generally done at a surgery center or in a hospital, and a lot of the arterial work is still done at the hospital.
Let's talk about varicose veins. What are they?
Varicose veins are bulges that you see protruding from the skin. They're veins with extra blood in them, more so than normal, and it causes a stretch of the vein itself, which is actually a muscle, so the veins are stretched and bulging through your skin.
Does the thickness make a difference, or is that just based on the person?
Basically, varicose veins form because the veins aren't functioning correctly. There's a vein basically generally underneath the varicose veins that is not working, and blood is traveling downward, putting pressure on its branches, and then that pressure causes the vein to dilate.
Well, you kind of answered my next question. I was going to ask you, how are varicose veins formed?
That's pretty much how. There's generally what we call a feeder vein, meaning a vein that runs like a roadway along the length of branches or side streets. And instead of going, blood generally in a vein goes back toward the heart. Instead of doing that, it goes in the wrong direction for a period of time before it goes back toward the heart, and that puts pressure in the wrong direction on the branches, and those branches dilate.
Are they dangerous?
In general, varicose veins run a gamut of symptoms. So people can have no symptoms, and of course that's not dangerous at all. People can have pain, and that in and of itself is not really dangerous. The ultimate risk of having what we call venous disease and varicosities is to have a venous ulcer, and that can be dangerous because it leads to non-healing wounds.
Okay. Why do varicose veins hurt?
A lot of times varicose veins hurt and feel heavy because, again, there's venous, what we call venous hypertension. There's a lot of extra blood in these varicose veins.
Pressure.
And pressure. Also, there's nerve fibers on the outside of the veins that when they're stretched, people feel it. They're painful, and they can also itch.
Can they cut them? Like, can they have an accident and they cut them? And
Sure, varicose veins bleed, and it is a cause for people who bleed a lot to go to the emergency room. Obviously, you just want to hold pressure if something's bleeding, but it is a risk of having a varicose vein certainly close to the surface, that if you were in a shower and you're shaving or something along those lines can absolutely cause a pretty significant bleed.
Yeah, that's what I was thinking. Like if they shave their legs and they cut themselves, Can you stop it?
Well, you can. A vascular surgeon's job is to stop all bleeding, so I can stop hopefully any bleeding. But generally, if
at the time, I mean,
if you're bleeding, you want to just hold pressure and then seek medical attention at that time. Varicose veins can also thrombose, meaning they can clot off, which is also painful because there's slower flow. The slower flow can cause the blood to actually clot.
So there are reasons to get these.
There are
removed.
Absolutely reasons to get
Not
them
just
treated.
vanity.
Not just vanity.
And here I was before thinking it was just a vanity thing, that they served no function and they weren't, because like I think I told you this before when we weren't on camera, that my grandmother and her sisters had them pretty much their whole lives and never did anything, and they were just like, they're nothing, don't worry about them. But they were in pain.
Yeah.
Yeah.
Yeah, they can cause pain.
They were in pain. The top polled question for my audience on varicose veins was, do varicose veins go away after pregnancy?
Varicose veins can shrink, certainly, after pregnancy, and some of the symptoms can be alleviated, but oftentimes there's been pressure and hormonal changes, and the veins are dilated, and they don't go back to the way they were, and that's a reason to be treated.
Would you recommend not getting it done while someone is pregnant?
Certainly, I would not recommend getting these veins treated during pregnancy. And
so wait.
Yes.
Wait. Wait till the kid's born.
Yes.
Okay. So what are the main symptoms?
The main symptoms of having venous reflux or venous hypertension is you can have heavy legs, itching, painful legs are the main symptoms that people come in, swelling of the legs, and honestly ulceration is the last thing that people come in with.
When you talk about heavy legs, does it mean that it makes them harder to move?
It actually makes their legs feel heavy. People have a complaint that my legs are really heavy and aching at the end of the day.
Okay.
And that's a big complaint.
How do you diagnose varicose veins? Is it an MRI? Is it an ultrasound?
It's the ultrasound you get when ladies are pregnant.
Sure.
It's really benign, and it's a probe used to penetrate the skin to look at the flow of blood within the vein. And so we can look at how dilated the vein is, whether there are clots in the vein, and also the flow within the vein, if it's going in that wrong direction before it goes back to the heart because of what we call valves not working within the veins. In our legs, we have one-way valves. Because we stand upright, generally people get varicose veins in their legs because the veins in your legs have to work against gravity to get back to the heart. So it makes sense that over time, the valves in your legs give out before other veins elsewhere in your body.
Now, is that ultrasound done in the office as well?
It's done in the office.
Okay, so everything's done right there.
Everything's done in our office.
Awesome. How is venous reflux and varicose veins treated?
So, again, when someone comes in with varicose veins, it's a whole picture of a whole, human being. We want to make sure, first of all, that they have a primary care doctor and that their heart is being looked at and their medicines are right and their blood pressure. But when someone comes in with varicose veins, I want to make sure, again, that they have good pulses and their arterial flow or the blood flow away from the heart is okay before I ever look at their veins. Because some things take precedence over varicose veins. But when that person comes in, again, we look at them as the whole person, and we look at the map of their veins. What veins are underneath those varicose veins that aren't functioning, and treat those first to try to shut down some of the blood supply and shrink the varicose veins. And we can, a lot of times, shrink those varicose veins without ever, removing them. But if they remain, we can either inject them with certain medicines or remove them. And then finally, we get to treating the spider veins if those are left over. But it's a stepwise progression with a good carried out plan.
Right. Well, one thing that just sparked in me when I was listening to that was when you said you treat the patient as a whole. So you're saying sometimes there could be underlying things that might need to be treated as well, not just that. When you're checking the patients out, you're going to make sure that their heart and their blood work. And now, do you want them to bring those with them when they come see you, or if they don't have them, you're going to tell them to get those things done?
I mean, I think with any good physician, you have to do a good history and physical and make sure that you know the patient and you know what's going on with them to make sure that there's no other underlying issues.
Yeah, and I didn't even think about that. What's the best one you recommend for the varicose veins?
In terms of how I would treat it?
Yeah.
I think there are many modalities to treat varicose veins, and I don't think picking one over another is right, because every patient is different and every patient requires a unique strategy.
Right.
And we have, because of technology, many different strategies to treat the underlying veins. There's, like I said, Claravane and Venocele and venous closure and Varithena. And so we can treat them based on how deep the feeder veins are, how tortuous they are, and so it really depends on the anatomy of the individual to pick the right therapy for them.
Understood. And what is the recovery like?
So the good news is the recovery is really minimal. People come in, I do the procedure, I wrap their legs, and they have to wear a compression sock for the week after that. But really, they can go back to primarily all of their activities almost right away. There's no high impact aerobic activity or heavy lifting for that week, but certainly they can walk a few miles to maintain exercise the very next day.
So you're saying that after it's done, they don't have to leave with crutches. They can walk on that foot.
In fact, we get people up right away and walk them right after the procedure to make sure that, we get their circulation going right away.
Oh, okay. So you make sure it's all...
We make sure they're walking.
Oh, see, I thought that they stay off it.
No.
Oh, okay. You get them right on it.
Yep.
Well, my mother-in-law just had hip surgery, and they literally had her up, I think, in less than an hour after they got her out of anesthesia.
Right.
They made sure she was right. They're like, come on, get up, start walking. So same kind of...
Yeah.
Yeah, okay. On a similar topic, I want to talk about spider veins. What are spider veins?
Spider veins, or telangiectasias, are really tiny capillaries that are visible to people under the skin. And there are also branches, or can be just cosmetic, or they can be a symptom of underlying venous disease. So really, the spider telangiectasias, as we call them medically, have a wide array of what could be either underlying venous disease or simply cosmetic. In and of themselves, they're not dangerous at all.
Okay, so once you diagnose that they're not dangerous and the patient still wants them gone, how do you do it?
There are really two FDA-approved drugs now, polydocanol or sodium tetradecyl sulfate, and we inject those into the vein. They're basically like detergents. We inject them into the spider vein. They irritate the lining of the vein, and then we compress the leg with stockings so that those spider veins close. Generally, they can get darker before they get lighter, and it takes 6 weeks to see full effect, but that's how we treat spider veins.
And you're injecting them with a needle? And
Yes, a very
does
tiny
the needle hurt?
No. Under the right hands, it doesn't hurt.
So it's not a big gauge. It's a very small gauge.
Small gauge.
And
yeah,
just a little bit of the fluid goes in there.
Correct.
Okay. And is that something that takes an hour in and out?
It really doesn't. People come at lunchtime and we can inject them. And again, it takes a little bit of finesse, because if you inject too high a concentration, you can end up with what we call staining of the skin or brown marking. Too little a concentration will have no result. So it's finding the right concentration again for the spider vein.
Can these spider veins come back after you do the procedure?
I think spider veins definitely can come back over time. It's almost like weeding. Like, you will get spider veins again in the future, but it's just a matter of upkeep, and when you treat it, it does last for a period of time.
Could they come back in the same spot, or they would come back in a different spot?
Sometimes they come back in a different spot.
So are varicose veins and spider veins covered under general insurance?
I would say that varicose veins, when they're part of venous reflux or venous disease, are definitely covered. This is a medical condition. So when we do ultrasound and we find that there's an underlying problem, that the veins are refluxing or not working appropriately, they are covered by insurance when the patient's tried conservative therapy like compression socks and Tylenol. On other occasions, if someone just has spider veins and comes to the office and says, my leg does not hurt, I don't like the way it looks, then certainly that's cosmetic.
That's cosmetic, and then they'd have to pay out of pocket for that.
Mm-hmm.
So what separates you from your peers?
One is I'm a board-certified vascular surgeon. Certainly in treating venous disease, you would want someone who's had the depth of training that I've had, not an internal medicine doctor who's trained on the side to treat varicose veins. I've been through general surgery residency and then vascular fellowship. I also think it's important to teach. I teach medical students and residents about vascular disease, both arterial and venous. I give lectures to them. It keeps you on your toes, certainly, for questions to ask the medical students and the questions that they ask you.
Yeah, I would think that that keeps you razor sharp on all the latest things that are going on. Plus, they're going to challenge you, right? So you're going to learn and grow with them and just keep on the cusp of cutting edge stuff.
Well, yeah, I mean, it certainly keeps you up to date because you'll ask them to read journal articles and things along those lines. And so it's really important to continue to read and continue to teach.
It sounds like you have a passion for teaching.
I love teaching. I think that it's important to teach people how to operate and to also teach people about arterial and venous disease. If they're going through medical school, they should know the anatomy of it and what causes venous disease, what causes arterial disease, even if they're not going into vascular surgery, because it's important to know.
And you're giving back, right?
Like, yeah, it is. It is definitely giving back.
I think that's amazing. Well, I think that definitely sets you apart from everyone else.
Oh, thank you.
Okay, this segment of the show is one of my favorites. It's called Stat Chat. Stat meaning, it's a medical term meaning right now, and chat meaning I'm going to ask you a series of fun questions quick. You have 1:30 to answer as many as you can, and you win nothing when it's over.
Okay.
You ready, Matt? Start the clock. Favorite sport?
Running.
Favorite team?
Yankees.
Favorite player?
Nick Foles.
Favorite type of music?
And now where I like to listen to rap, but I also like classic rock.
Rap?
Rap.
Love it. You must go to see one concert, Taylor Swift or Lady Gaga?
Lady Gaga. I love Lady Gaga.
Me too.
I want to meet her.
Me too.
Yeah.
I really do.
Yeah.
Favorite movie of all time?
Titanic.
Yeah. You want to do the thing?
No.
No? Favorite actor?
Matthew Rhys.
Who's Matthew Rhys?
He was on The Americans, and he's been in Sisters
Americans.
or
Okay.
something like that.
Yeah. Coffee, leaded or unleaded?
Caffeinated?
Yeah, leaded.
Leaded.
All right.
Yeah.
Last fast food you ate?
I try to stay away from it, but I probably stole my daughter's fry from McDonald's.
Can't beat a McDonald's fry, you really can't. Favorite word?
Dream.
Oh, I like that one. Salty or sweet?
Sweet.
You're trapped in a supermarket. What do you eat first?
Grapes.
Grapes, not an Oreo? Okay. Grapes. If you weren't a doctor, you would be?
A techie or a writer.
If you could talk to anyone, dead or alive, who would it be?
Probably Sophia Ionescu, the first female neurosurgeon.
The last segment we do is called Before You Go. This is where you give one tip to future patients that will help them navigate their visit to you at your office.
I would say that you're coming to me, I want you to ask me all of your questions, that I will sit there and not rush and legitimately figure out what's going on beyond, if you had any other questions beyond your vascular questions and your vascular questions. I want to make sure that we treat the whole person and we're thorough, and that's what I'm there for.